vej. Vi kommer gående nu. Yeah, you can also connect. Just switch if that would be easy. So we have just a presentation first, and then.
Let me put it on the stick because I need an HDMI.
Yeah, just put it here. Sorry. Can you take your coat? Yeah, just one. I can take it.
Sure.
Stick here.
Der er nogen, der har puttet min frakke away som blå her.
Second.
Jeg prøver at se, så er vi her. Okay. Godmorgen. Undskyld, vi lige er i sidste øjeblik. Vores gæster skulle lige finde stedet, og jeg tror, vi havde givet en forkert information, så stod de ved akutmodtagelsen, og der var ikke nogen, der kiggede på dem. Så sådan var det. Nå, velkommen til morgen. Husk lige, også af hensyn til jer, der er med på streaming, at I kan gå ind på Twitter og stille spørgsmål. Og der er den sædvanlige opskrift, den ligger her på bordene, og I kender den også. I kan gå ind og få en Twitter-konto, hvis I ikke har den. Det er nemt, og der er mange spændende og sjove budskaber at give til hinanden på Twitter. Okay. Så svinger jeg lige over til engelsk. Our guest today is Peter Back. I call him clinical CIO because he's a physician too. And he's from Humber River Hospital in Ontario, Canada. And I think he will postulate that it's the world's most digital hospital. Let him prove that for us. But we are very, very happy that you are here because you have been through a process that we are coming through and running through. We, in reality, are working in the same way. We have the same issues. And I think Peter will tell us a lot about how it is to build up that hospital and move to such a hospital, collect staff members to such a hospital. There's no choice for the members of the staff. You have to work in a digital manner. But I know that it will lead to a great cultural process even after you have become digital. And I think that Peter also will tell us something about mobility, digital mobility. So we are very happy that Peter are here, and we will show him what we are working with in the next days. He already have met a lot of us, and we will welcome Peter. I have to leave in a few minutes because we have a WIN conference, WIN festival, but Torben, who really is responsible for the new hospital, will listen intensely to this presentation and take over. And the directors will continue the day together with Peter Back. Welcome, Peter. And now it is so that we are collected in this room, the staff that has the possibility to be here personally. The rest are sitting around in the house, and you will be streamed. So, and question will be asked, and they have to ask the questions in a mic because it's also picked up.
Sure.
And it's possible to people to see it later. Thank you for coming. Welcome.
You're welcome. Thank you. Okay. Good morning. Ooh, I've got to stand away. Well, thank you for inviting me. I'm going to hold this. I have to watch my time here perfectly. So I'd like to tell the story of our journey. We engaged in building a new hospital already many years ago, and we finally opened the doors in 2015. And we went through a full digital transformation. And from that transformation, we recognized that our journey is just starting. And we are now into the second phase of our journey, and we have one more thereafter. And I'd just like to present to you what those journeys are and what we have done. I'll just start this with putting a little bit of context, and I think hopefully everybody here this will resonate with you. This slide I got from a conference in the US, and really this slide is saying that the United States healthcare system is not so great. It gets very good care, but if you look at the big metrics as a system, it's not the best system in the world. It's expensive. Their outcomes are not better than ours, but there are challenges. And this is true of all of our systems, and Canada is no different. In fact, our system is very similar to yours. Our metrics may not be the same as yours, but I'll just give you some quick insights to our metrics. So we have a lot of patient readmission. One thing that Canada is not so good at is managing the flow of patients from your primary care physicians into our emergency and acute centers. We have a tendency for everybody to come to the acute center all the time. We have mistakes, we have harm. I think this is also true in pretty much every hospital, but the degree of harm will depend on where you are. This is not a figure that we're proud of, but it's a reality. Our expenditures are high. We can do this by GDP. I like to think of it as the percentage of budget of our country. For the province that I live in, 47% of our annual budget goes on healthcare. This is unsustainable. The cost of stay in an acute center is the most expensive. I think we all understand this. In Canada, it can cost you up to about $10,000 a day to come into our hospital. All of this is to say that we need to do something differently. And this is a very interesting paper or article that I read in The Economist, and it's sort of highlighting a lot of these facts that in the future, or not too far future, the system is going to ultimately break. And unless we do something quite different, we're going to hit that wall. Things are not going to be so good. So what do we do about that? In Canada, we've been thinking about reducing cost, improving care, all these types of things everybody is doing. But they're a little bit too incremental. We need to do something that's more radical, that's more disruptive to the overall system. And at Humber, we're taking a position that we as a hospital are actually a sort of a big force of energy with a lot of capability, and we should influence the way that healthcare is managed and delivered in our community. And in fact, our community was asking this of us. We went through a strategic planning exercise. We consulted all of our community, and they were asking us to do this. So we said, great, good idea. What should that really look like? And So in our mind, we wish to be the hub of our care that goes on, and care isn't just about acute sick care, it's about well care, it's about nutrition, it's about coaching, all these other elements of looking after our patient population. We should be involved in that. And so how do we get there? And this is the journey that we believe gets us to become the hub of a healthcare ecosystem in our community. And the first step is digital transformation, and we've completed this and seen significant benefit from it. So let me tell you that story, and then we'll get into the next two stories. This is Humber in the past. We were 3 very old buildings. The quality of care was pretty poor. In the scheme of things, our metrics were not great. And I think there are a lot of older places that might have this same sort of gray, negative kind of environment. And this is our wonderful new facility. And it's definitely nicer than the previous buildings. But more importantly is we completed the digital transformation, and as a consequence of that, these statements can be made. They're not made by us. Well, maybe the first one is, but the other 2 are not. And when we set out to move into this new facility, it was not just a digital transformation, it was a lean transformation and a green transformation. I'm a CIO, so I'm a little biased. The lean and the green are care of the digital. So, although the lean and green guys don't think so. But the digital side, we kind of make a claim that we're the most digital hospital in the world. We started off by saying we were North America's first fully digital hospital. And since opening the doors, we've had people from around the world come and visit. And every single one of them says they have never seen an organization operate with the level of digital capability that we do. So we wonder whether we may be the first in the world, or the most in the world. But the second comment is really interesting, and this is not so much for the clinical folks in the house. Well, it is somewhat, but as administrators, driving down the cost is very much the name of the game, while driving up all sorts of other metrics. And we have achieved that. We are the most cost-effective form of acute care in Ontario. I don't know about Canada. And this is very much because of the digital transformation that we undertook. And I'll show you some examples of this. And another very interesting part of this, and this pertains to the building of the new hospital, is that we are a very green and energy-efficient building. And in terms of dollars, the expected, if we had done nothing other than just be normal, then our energy bill for the hospital over 30 years would be $250 million. So we have reduced our energy bill by 60% by using digital technology and innovation on the building side of the project. So just a quick snapshot of what we look like. 656-bed hospital. This is mixed between surgical and medicine beds, no long-term care beds or rehab beds. We are a very busy emergency department. We are now doing around 400 to 420 patient visits a day. This is well beyond what we were originally planning on, so it's a very busy place. So just the digital transformation is a long story, if I choose to make it long, and I'm not going to. So I'm going to jump into 2 of the key elements of this, of what we did. Let me start by saying that what I found interesting is that I started on this project in 2009, and at that time, trying to articulate what a digital hospital is or is to be was very difficult. In fact, I sort of, the lesson learned I have this is that you start with a very, very high level statement. Oh, it's digital with better quality and safety and efficiency. There you go. And that's not very useful. So then you say, oh, but it's digital because, and then I take 2 hours to tell you about every little piece that's going in. And after 5 years of doing that, you suddenly see a picture emerge and how to articulate it. And that's very, very important for people to be able to follow that vision and to embrace that vision. And that was part of our journey, is learning how to get our staff to embrace it. And we have landed on describing a digital strategy or transformation in the theme of these 4 items here. And I'm going to talk about 2 of them because they are the foundation for the next part of the journey. Electronic information. As clinical people, we all understand this. We go electronic charting and moving entirely to a paperless world. And that definitely is an objective and an important one. But what's interesting about electronic information is we all know that electronic information is available to anybody, anytime. That's very useful compared to paper. But really the power of electronic information is the second bullet there, which is that it is actionable data. And actionable data is a term now used, and it's often used in context of big data, machine learning, AI. It's actionable data that gives you knowledge of what you should do and drives you to do things. We have actionable data all the time on our phones when our calendars pop off and say you have a meeting in 15 minutes. Or in our case, we didn't pay attention and kept sleeping. But so what is interesting also is that in a new building, it is not just your electronic chart that should be electronic. Your chart that should be electronic. It is everything in your building that should be electronic. So in our facility, we have a real-time locating system that is 100% coverage. So we track assets, we track people. That's not a chart, but that is very useful electronic information. We have every single piece of equipment in the building is electronic, so that it can send us alarms and alerts, and we can find where it is, and we can do all sorts of things with it. So when I say everything, that's all of our infusion pumps and all of our vital sign monitors. That's somewhat obvious, but then also our lighting system, our heating system, our cooling systems. These are all on our network, producing and controllable by computers. And that's actually part of how we achieve that energy saving, because all of the mechanical electrical systems are electronic and connected to our network. So on the charting side, I'm not sure if you're familiar with the HIMSS MRAM scale. If you're not, then this is a means of describing a sequence of how to become fully electronic. And the top of the scale is 7, and you can go look this up and you'll see they list what it takes to become MRAM 7. We are just a tiny bit away from MRAM 7. But really what it does is it says you need full nursing documentation, full physician documentation, provider order entry, 100% everywhere. So we've achieved all of that. Bedside medication verification, closed loop medication as they call it. We have implemented all of these things. And the implementation was not all that difficult to do, quite frankly. I don't want to minimize the amount of work. It takes a lot of work. It takes a lot of champions to champion the initiatives, especially amongst physicians. But it's very doable and you can get there. And when you do, the benefit is significant, very significant. To give you a quick feel of those benefits, labeling errors in our hospital is 0. Infection rates have come down by an order of magnitude. Bedside by nursing staff is orders of magnitude greater than they were in the old buildings. And you'll see some pictures that kind of indicate that. Staff satisfaction rates are much, much higher. Patient satisfaction rates have gone right up. And those measures are done by our government, and they are not just, do you like the place? It's about measuring the quality of care that they receive and the respect that they receive from us. And those measures have gone up. I'm just going to talk about mobile and connected, because this is the second key foundation to the rest of the journey. And by mobile, we all think of handheld devices and tablets. This is part of being mobile. Mobile means access to information anytime, anywhere. And that doesn't necessarily mean a mobile device. That can be a combination of carts, or wows or cows or whatever acronym you use here, but also fixed devices on the walls. And implementing the application so that you can tap in, tap out very quickly and launch your medical record right at the right location. So that you can use your bedside terminal as a charting station if the room is in infection mode. A whole combination of methods defines being mobile, not just handheld mobile devices. And as you think about moving into a digital or completing a digital transformation, there's a lot of thought that you do around this in your environments, in the physical spaces that you have. For example, on our inpatient units, every nurse has a cart. But in the ED, there's no space for nurses to have carts, so everything is wall-mounted in the rooms. To the point where we do bedside labeling for nephrology, for sample selection. We have mobile carts for our technicians, but in the ED, we have a label printer mounted on the wall because those carts don't work. So these are all examples of what it really takes to be mobile. The second piece is about being connected, and this is, I think we all know, is really key. People-to-people connection is a big problem in healthcare. We don't have the ability to connect fast enough, so things get delayed or decisions are not made in a timely fashion and have negative outcome. How do we solve this problem? Today, I think, I don't know about here, but certainly in Canada, we still use a lot of pages and telephone calls. This is very inefficient. And none of us communicate that way anymore with our children. They all communicate by text. So why aren't we doing that in healthcare? And we should be. But interestingly, just taking your iPhones and instant messaging away is not productive. That doesn't solve the problem. And what we found is that there are actually 3 different ways in which people-to-people connection happens. One is casual chat. So I want to have a conversation with you. I'll use all my consumer-related applications, although in our case, we've deployed all of that technology in a private server setting using Avaya communications, but you can use Cisco. There are other technologies. We found that there is also a need where nurses will notify physicians, please remember tomorrow morning, do this with your patient. And physicians don't want that to come on their phone, because then they have this long list of stuff, and maybe the nurses will remind them in the middle of the night during night shift, and they don't want that to wake you up. So how do you deal with that? So we do this in our charting system. We call it rounding or I-rounding. And we have little notes in our chart. So during rounding, you pick that up and away you go. But it's the third one that's very interesting, and here we call it IC, which is critical clinical communication. And this is where you want to use your instant messaging video conferencing tools to connect in context. And in context means which patient, which care team are you talking about, what's the level of urgency, and closed loop. That means that you need to tell me that you have received my message, you're engaging. And this is about ensuring that clinical decisions are made quickly and effectively with the right information. And this can all be done with instant messaging technology, video conferencing technology, but you need to layer an application over it because you need to be able to pick up the patient identity, the nurse that's responsible, the roles that are responsible. And by the way, that becomes multimedia because the power of an image is huge. We have physicians that say, just take a picture of your screen so that I can see what we're talking about. That's faster than telling me where to go into the medical chart. Logging on, going to the patient, finding which lab result we're talking about. Just take a picture of it and I can see it and then we're done. And you may go, well, that's kind of crazy. They even do this with x-rays, which I'm a radiology guy and I look at this and I go, oh my God, you're looking at an x-ray that you've taken a picture of. Why don't you just look at the real DICOM images? But they don't care for that because it takes too long. And they can make a decision quickly by just snapping a picture and sharing it. Same with video. You can think of all sorts of scenarios where this is useful, but it has to be done in context. So we talk about the 5 rights, and the communication tools need to support this notion. So we've implemented this. The last piece of connected is that not just people to people, but systems need to be connected to people. What does this mean? If you have actionable data, then that system is going to have intelligence about what needs to be done and notify somebody, please do something. That's system to people connection. So you need to have a platform that allows that communication to happen. And again, it's about the right person at the right time. If you just alarm and alert people on an event and you splat it out there to everybody, it's useless. People don't pay attention and it's not relevant to you. So your platform has to be knowledgeable enough to know this message needs to go to this person right now, and please take action. So this is very key to your digital transformation and achieving the benefits that come with it. I'm just going to show you pictures here very quickly of what our facility looks like. I would love it if people afterwards offer their comment, but on the left, that is one of our inpatient units, 32-bed unit east, 32 beds on the west, all single patient rooms. We have an on-stage, off-stage design, so all around the outside of the patient rooms and in the center core is where all of our internal services happen, so patients and family members never see that. That is a busy day. There are no nurses hanging around. They are in the rooms. On the right, that's our nursing station. There are not a lot of people sitting there and there's not a lot of paper. This is a normal day. In the middle is our nurse's cart, and you'll see there that this really is their work surface. They have their meds in those little blue containers there, and they're actually locked, so you have to key in. But this is their workspace, and they move around and go into the rooms with that, but then we have bedside terminals in the room so that if infection is in place, then they don't take those in. So that's the digital transformation, and there's plenty more. There's full systems automation that we've done. There's a lot of things that we've done, but in the essence of time, I'll move on. Having done that transformation, we are now moving to what we call high reliability organization. What we saw is that the opportunity now to really shift and become even more efficient and even better from a quality and safety perspective is right in front of us. And so our journey is to achieve high reliability hospital status in the next year or so. And if you're not familiar with high reliability, this is actually a whole discipline that was developed in the 70s by the US Navy to make sure that people on aircraft carriers don't make mistakes. If they make mistakes there, it has quite significant consequence. And so the same theory is being applied in hospitals in the US, and we are engaging in that at Humber. So how do we move to this status of high reliability? And just to summarize that, high reliability essentially is I'm going to eliminate all mistakes in my hospital. And the way that we plan to do this is to implement what we call a command center. And through that command center, well, let me show you, I don't know if what time is it? Do I have time?
It's a video.
It's oh, okay. I'm going to have to pass on the video, then I'll just have to describe it. You guys can actually watch this video. It's on YouTube. If you search for Humber Command Center, you'll see the video. Please do look at it because it explains the concept very well. But this summarizes it. So what is the command center? It's a physical space where we put a lot of our existing coordination people that do bed management, care coordination, transport coordination. Instead of sitting in their offices around the building doing their job, we now put them into a single physical space and then present to them information about what's going on in the hospital at any one time. And it's hard to see here, but you'll see on the right there, analytics tiles. So this is really what the heart of this system. we have all this electronic information. We can now take a view of everything going on in our hospital. And with the right analytics and smart algorithms, it can present to us information that tells us we have problems. Go intervene, solve that problem. The motivation for this actually started off with not high reliability, but started off with capacity. When we opened our doors, we were supposed to grow for 5 years. We were full in 4 months. So the planning, and this is typical, you do all this planning, it takes 12 years to plan this facility and open the doors. So when you do your functional programming, your census data is completely wrong. And you don't know that, you can't really predict. In our case, we're in the city's intensifying quite rapidly. So we have a far greater population than what was thought. And that's why we're busy. So we sat there and said, how'd you solve this problem? You know, and as is often the case, your surgical beds are consumed by medicine beds because medicine beds, they are what you just need them. So our elective surgeries get canceled and delayed. And we had to have 25% growth in elective surgeries, and yet we needed to have similar growth in our medicine beds. How do you solve this problem? We looked at this, and the command center is going to open up 40 additional beds of capacity without increasing any physical infrastructure or actual beds or any staff. This is about pure efficiency. And with it comes quality, or actually the other way around. With quality comes efficiency. So this is what the command center is about. And the way it works is that we present all this information, and I'll show you a couple of slides. And then from those analytics dashboards that you get, you take action. So when things start to go, you know, a little hot, or you have units under pressure, or your ED is backing up, what do you do? And the what do you do is what you see at the bottom right. And we are doing this with GE, and they coined this, the phrase they have is an IPOM, and it is an interactive procedure operating mechanism. I like to use the analogy of the Apollo 13 movie. I don't know if you ever watched that movie. Where Tom Hanks is in space and everything's going wrong. So down at NASA, they say, okay, guys, go work out how to fix that. And they all run off, and they come back and they say, here's how you do it, press this, do this. This is what an IPOM is. I've got a, except instead of doing it after the fact, we create these IPOMs now so that our teams know what to do when we go under pressure and things are not going right. And then the last piece of this command center is communications, and this is why I try to highlight the point that when you have something going wrong, you need to communicate with people. You don't pick up a phone, because then you're never going to get them. So that whole communications platform, which requires IC, or critical clinical communication, this is critical clinical communication that's happening. So I should be able to push a button, and with all the right context and the right role and the right person and the right action is embedded now in that message, and it goes out. Because we have all that knowledge by being electronic information. So all of this hopefully gives you, and I'm running out of time, I'll run through these a little bit. These are just examples of some of the tiles and the benefits that you can see here. So you can see here, can we accept an ICU patient later this morning? We have a tile that shows us what's going on in every single one of our med-surg units. How many beds are available, what's already been admitted, where the discharges are looking. All that information is presented, so the team can now answer that question and make decisions. Here is one, and I'm just show this one because this is our step towards high reliability and eliminating never events. So here you'll see an example that says sepsis diagnosis med event greater than 45 minutes on 14 East. We know that if you are diagnosed with sepsis, you have to take action immediately. And every minute that you delay leads to potential negative outcome. So here we can measure this. A diagnosis is done, it's in the chart. The timers go. If action is not being taken, why not? And our team now needs to intervene and call those people and say, you need to get on with treating this patient. So this is more of a reactive method. Our goal is to actually implement early warning systems so that we can actually predict before these events happen and intervene to avoid the event happening altogether. Early warning systems are available for cardiac arrest. We know that they are proven, and GE is working at Johns Hopkins on an early warning system for sepsis. And we will do more of those as we go. The bottom one is about clinical pathways, and so if you are diagnosed with stroke, we know how to treat you, we put you on the pathway. This is about ensuring that you stay on that pathway, that you don't deviate, increase your length of stay, increase your cost, and all the rest that goes with it. So, these are just some more slides. This is an example of an IPOM. We don't have time to go through all of it. Here are some more actions and tiles. All of this, at the end of the day, the intent is that this command center provides us with an environment to be able to get increased capacity, move patients through our facility faster and better, and then eliminate errors. That's the goal. And we have implemented all of this. Sorry, this is the communication piece. It takes work to do this, and if you're doing a digital transformation journey, then plan this journey at the same time. We've done it, so now we can tell the world what it takes to do it and the benefit of doing it. We see lots of benefit, and we will be opening our command center November the 30th, so this year. And so this is lots of information about what it takes to do. This is the important slide. GE has, I'll just give you a little history here. In 2008, we hired GE to help us with our lean processing. So the lean, green, and digital, they did the lean. And we said to them, how come, we see all of these operation centers for FedEx and for, Dell, and they can track every single piece of equipment that's floating around their organization in the world, wherever. How come we don't do that for patients? GE turned up in 2016 and said, remember that discussion you had? Well, we've now built that for you. So it was very interesting that GE may not agree with this, but the ideas of this command center actually originated with our team back in 2008. They implemented at Johns Hopkins first, we're the second, and now they have many, many people that are taking interest in this. And the effort to build this is quite significant, but that's because we're number 2. And I think every other hospital that engages in something like this, it'll become easier and easier as you go. Okay, last, and then I'm done. Care coordination. This is the next phase of this journey. We will be complete with high reliability by the end of 2018. And then we engage in care coordination. And this is where we want to start engaging as a hub of the ecosystem. Wearable technology is pretty commonplace now. The technology piece of this is not that difficult, I don't believe. What's more complicated is the programming. How do you set yourself up so that we can intervene with patients at home, provide guidance to them, and have local community workers go in and coordinate with us to go and address the issues with the patient. From my learning of being here in Denmark, you guys have worked around that quite a bit and done quite well at that. We really do a bad job of that. Now it's our chance to go and make that work. And the core thing that I look at for this is you need to be able to operate out of the command center with analytics to drive all the data coming in, filter it all out so that only the right piece of information is presented, so that a small team of people can manage a very large population. That's the goal. At the end of 2019, we hope to be doing care coordination in our community. So when we are completed with that, we'll come and tell the world how that went. Just about.
Well, thank you. Well, thank you very, very much, Peter. That was very inspiring, I think. Are there any questions for Peter? There's one there, Peter.
So how do we achieve actionable data? What do we take for us? So actionable data, actually, if you go fully electronic with your medical record system, and I don't know what you have here, we have Meditech, which is one of the big US guys, so there's Cerner, Epic, Meditech. All of our data that's actionable is actually coming out of Meditech. So your charting information, you can extract a huge amount of knowledge out of that. 90% of our analytics that we're doing is fed by data coming out of our electronic medical record. So first thing is start putting physician documentation, CPOE, all this information electronically, and then you have data that can drive action. The other piece that drives action are a lot of your equipments like your telemetry systems, your vital signs monitoring. You can extract a lot of information, and that also becomes actionable. Hopefully I've answered your question.
Yes.
You have to...
Actually, two questions. Are there any laws locally within your country that are sort of limiting your ability to digitalize your hospitals?
No.
Great.
Short answer.
Nice.
No. Nobody said we couldn't do anything that we did. The only thing, one anecdote that is pertinent is that we have a real-time locating system, and every staff member has to wear a badge. And we have unions, I think the same as you do, and so the unions are all up in arms that we were now going to track everybody when they go to the washroom and all that, and we said, no, it's not what it's about. So we had a kerfuffle with them, but we got over that, and they realized that it's actually a safety benefit and a performance benefit for them. So that was the only thing, but that wasn't a law. That was more, unions clashing with administration.
Thank you. How was the metrics on research in the same period? Did it increase, or was it stable, or more papers in high-impact journals, etc.?
Well, we're not an academic center, so we haven't done any research papers, if that's the question.
Yeah, that's actually how this digitalization is interacting with the researchers. Is this making it more easier for a researcher to get access to relevant clinical data for new ideas?
I'll tell you what I believe, and I can tell you a year from now, because we're not an academic center, so we don't do research. However, we are becoming an academic center. We are a community teaching hospital. We are now going to do academics, but we are writing scholarly papers and doing a lot of research on all the quality benefits that we've achieved. So we do have a team that is doing that, and we will be publishing 14 or 15 papers on this in the next 6 to 8 months. Yes.
I think we have just the time for one more question up there. How much staff and what kind of staff in the command center?
Okay, the command center, 10 people in the command center for now. When we move to the generation 3, when we do care coordination, that'll probably increase to maybe 15 or 20. And the people who are in the command center, they are all the same people that you have in your hospital today. No net new roles, with the exception of the director of the command center and the medical director. So we actually have seconded a physician who will be in the command center 50% of the time.
Okay, one final question. You talked about all this as a journey more than a destination. What's next in 10 years? What's your next very, very big project?
So, drones.
Drones, okay.
Maybe not for us. So I don't have an answer to that explicitly. But what we have experienced, and I think this is the interesting piece, is when you engage in a digital transformation, you become aware of things that you would otherwise not become aware of. And when you become aware of that, you realize what more you can do. And what we expect is that as we engage in becoming a high reliability hospital, we will understand the inefficiencies and other things that we were just not aware of. So we in fact have a contract. Our relationship with GE is a 10-year contract with 7 generations of the command center planned for. Without knowing what those other generations are, we have 3 defined, we have another 4 that we believe will emerge. And they will emerge because we'll become more knowledgeable on the issues that we have. So that, I would say, is that journey will keep going, and there may be big disruptions as we go.
Okay.
That can be counted on.
Thank you very much.
Good. Perfect. Oh,
Ja,
thank you.
tak for nu. Fortsat god onsdag.